very important because EMQs are something which you always feel difficult, and we should know how to solve the EMQs, right? How to read it, how to interpret it, and how you should first make the answer in your mind and then go to the options and select your answers. Okay, so let us now, my job of speaking over. Now you should read and I should listen. So who wants to read this? Sorry. Yes, who wants to read this?
I'll go, ma'am.
Go for it.
For each scenario described below, choose the single most appropriate management options from the list of options above. Each option may be used once, more than once, or not at all. A 43-year-old multiparous woman presents to the EPAU at 12-week gestation with mild vaginal bleeding. She gives history of unprovoked deep vein thrombosis 1 year prior to this pregnancy and was treated with warfarin for 6 months. Currently, the GP has started her on aspirin in view of previous history of preeclampsia. So she's a elderly multiparous female with an history of DVT on aspirin now with vaginal bleeding. Prophylactic.
Yes, so what do you want to do?
I would want to monitor her INR, ma'am. Given her
Anytime, whenever you are starting heparin, you are going to monitor her blood test. That is a different thing. But you're not finding that option here because they are asking you how you'll manage her. What you want to give her, from when you want to give her, how long you want to give her. This is all option about. So what do you think? She has a history of DVT and unprovoked DVT. She's now 12 weeks pregnant. So what is the rule?
we can give her, we can withhold she's not on heparin also.
She's not on heparin because not all DVT will be forever in heparin, right? They will take for 3 months, 6 months, and then they will be done. So she was treated with warfarin at that time. She must have taken whatever needed at that time. Forget about that. That is not our problem. Our problem is she had a history of DVT. Now she's 12 weeks pregnant. What should I do?
Commence intravenous prophylactic unfractionated heparin. Option
Unfractionated. Why? What? So let us discuss about unfractionated then. What is the role of unfractionated heparin? When? Unfractionated heparin, my dear, has only one role, which is peripartum. When she is about to deliver, unfractionated you can control better. You can control better unfractionated because it has short half-life. It has the antidote, protamine sulfate. So whenever you feel a woman is high risk of bleeding, you don't want to give them low molecular weight heparin because it is longer acting as well as there is no antidote, no monitoring. So peripartum, not postpartum, peripartum. When you're planning either delivery in a high-risk woman like APH or something, or postpartum, you think she's at high risk of bleeding after PPH, APH, whatsoever. So in such situation, you will use unfractionated. Other than that, unfractionated is in massive VTE. When massive thrombosis, you have to give 80 milligram per kg followed by 18 milligram per kg maintenance. So that is the only two indication of unfractionated. Or sometimes if like you are doing cesarean, the same thing as I told you peripartum, if you are doing cesarean, she's on subcutaneous, so you will shift her to IV. IV heparin you have to stop only 4 hours, 6 hours prior. So that way you have a shorter window of without anticoagulants. That's why you shift them from subcut to IV. So that is the only role of unfractionated. As we discussed, low molecular weight heparin is always our first choice. So we want to give her low molecular weight heparin. What do you think?
So that option will be E, commence prophylactic low molecular weight heparin.
Very good, my dear. Yes, read the next question.
A 40-year-old multiparous woman presents to the obstetric day assessment unit at 28 weeks gestation with reduced fetal movements, normal cardiotocograph. Her notes indicate that she had DVT at 20 weeks gestation during her current pregnancy and is on 80 milligram low molecular weight heparin twice daily. Her booking blood results were normal. However, her recent blood test reveals a platelet count of 60,000 per liter. So she has got a low platelet count and is on therapeutic low molecular weight heparin in view of a DVT at 20 weeks.
Very good. So what do you want to do?
So
What is the contraindication of heparin?
thrombocytopenia,
How much?
less than 1 lakh, ma'am.
Less than 75, my dear. Less than
75.
75 is the contraindication. Now here it is 60. So definitely they have mentioned platelet for you. So they want you to know the level of platelet. So less than 75, you cannot give her heparin. So what to do now? What to give?
We can give her dalteparin.
Dalteparin. Is dalteparin not heparin? Dalteparin is also heparin. Tinzaparin, dalteparin, and enoxaparin. All are
Enoxaparin.
heparin.
Uh, we can give her an alternative of heparin or
Very good.
antithrombin. We can give her an
My dear, you
antithrombin.
cannot give her any heparin. Samreen, unfractionated IV, no. Any heparin is heparin. So you don't want to give her heparin. So you want to give her some replacement. So what is your first choice in replacement?
Heparinoid danaproid sodium, ma'am.
Very good, my dear. You will change her to danaproid. If that is not there, then what is your third choice? Means if danaproid also they say that you cannot give or it's not an option, what will be your next choice?
Warfarin.
Fondaparinux.
Fondaparinux. Okay.
Fondaparinux. You cannot give warfarin, my dear. So you will give her fondaparinux. Okay. So this is how you have to choose. Okay.
Okay.
Next question. Who else want to read? Or you can read one more Aarti and then next
Yeah.
somebody else can. Yes, go ahead.
A 30-year-old woman who delivered 8 hours ago gives a history of previous thrombophilia. Her mode of delivery was cesarean section for a prolonged second stage of labor. She had a massive postpartum hemorrhage and her current hemoglobin level is 8 grams per liter. The midwife comes to you to inform about the minimal soakage of the cesarean section wound dressing. So she's got multiple risk factors for thrombosis, postpartum thrombosis. One is cesarean section, second is prolonged second stage of labor, third is massive postpartum hemorrhage. So she's got 3 risk factors as of now. So I would like to start her. Um, uh, the answer would be Cummins prophylactic low molecular weight heparin.
So what heparin now you want to choose?
I'd go with low molecular weight heparin.
You all will give her low molecular weight heparin? Then where is the unfractionated now?
IV prophylactic unfractionated heparin.
Because she's massive
Peripartum.
PPH, her hemoglobin 8. So this is what I was talking about. In
Exactly,
peripartum, if
exactly. So
she is at
peripartum.
high risk of bleeding, you will
Mm.
choose unfractionated, my dear.
Unfortunate
So
heparin.
you
Yes.
will choose unfractionated prophylactic.
Yes.
Very good. Yes. Next question. Who wants to read the other two?
Shall I read?
Yeah, go ahead, my dear.
A 33-year-old multiparous woman is removed by the senior house officer in the postnatal ward. She had a cesarean section for failure to progress and has been using an epidural for pain relief for the last 4 hours following cesarean section. The midwife has just given her the first dose of prophylactic low molecular weight heparin postnatally. So, prophylactic dose, you can remove the catheter after 12 hours after giving the last dose.
Very good. So whenever you have given the dose, you will not remove immediately. So you will remove after 4 hours. Is what the answer. Very good. Next question.
38-year-old multiparous woman is admitted to the antenatal for an elective cesarean for breech presentation. She had a pulmonary embolism during this pregnancy and has been on a therapeutic dose of low molecular weight heparin, 90 mg twice daily for the last 3 months. She took her last dose just before coming into the ward. So patient, she is on therapeutic dose of low molecular weight heparin. So epidural analgesia can be given after 24 hours only.
Yes, very good, my dear. After 24 hours for therapeutic dose. Very correct, all of you. So if you see, these are the answers. So let us revise it. If you see prophylactic or therapeutic, if prophylactic, you have to stop 12 hours before. If therapeutic, 24 hours before. When you can restart 4 hours and 8 to 12 hours. All these are recall questions. When you will stop with prophylaxis, therapeutic, when you will restart after that, this is important. And then if you see unfractionated, it is 4 hours and 6 hours. So even not doubling, 4 hours and 6 hours. So always, even with therapeutic dose of unfractionated, you can stop 6 hours prior. And because this is subcute, sometimes they will give you unfractionated subcute. So be careful. In such situation, always it will be 12 hours. So this is a master chart of when you will stop and when you will restart. So don't forget it. Yes, next question. Who wants to read?
I will read.
Yes, go
I will
ahead,
read.
Dr. Yeah, go ahead. Yes, Dr. Gopal, you can go ahead. We cannot hear you.
Oh, yeah. Now you can hear?
Yeah, now we can hear you. Yes.
So we have to find the most appropriate next step. So a 34-year-old patient is seen in the obstetric triage unit out of hours at 26 weeks gestation with acute pain, tenderness, and swelling of her left leg. She is otherwise well with no chest pain or shortness of breath. So here we suspect DVT. So we will do the compression ultrasound of her left leg.
Very good. And I will kill you. You all want to
No,
investigate her. But
Not
what
in
about the
at
clinical
first.
thing? In VT, whenever you diagnose VT, what is your first
first,
step? What is
Start
most
therapy
important?
with low
Diagnosing
molecular
her
weight.
if there is anything or not, or treating her first?
first you have to treat her with
So first, you will always give, whenever a pregnant patient comes to you with sign and symptom of either VT, leg thrombosis or pulmonary embolism whatsoever,
yeah.
it is dangerous. It is life risk. You cannot tell her go to compression ultrasound and come after. My dear caller one, who is this now? My dear caller one, this is a free session. Still you want to come and disturb us? Yes. So, yes, Dr. Gopal. So, oh God. So, whenever you get any patient with thrombosis sign and symptom, your first job is to, they are asking you next step, right? Next step. So, your first job is to give her heparin. Now, whenever you want to give her heparin, you have to rule out the contraindication because she might be renal failure.
Yeah.
Then it is safety point that do her blood investigation, LFT, RFT, CBC before giving her heparin. Rule out the contraindication of heparin, right? So first you have
Yeah.
to do the test. Is she a suitable candidate to give heparin? And then you have to give heparin first. And then you will try to diagnose and rule out and all the picture remaining you will do later.
Yeah.
But the trailer first is do the blood test, give the heparin. That is what your first most important step. So here you want to do first her blood test before giving her heparin is what you should choose because they have asked you the next step. If they would have asked me most appropriate step, what I would have chosen here,
Most appropriate, we would have done
if
the.
they will ask me most appropriate,
Then we'll do the Doppler
low
ultrasound.
molecular weight heparin. No, my dear. Investigation you will do. That is there to do later to diagnose or refute your diagnosis. That is different. But first, you want to give a low molecular weight heparin. That is your most appropriate action. Next step is do the blood test before giving heparin. But most appropriate step is give her heparin. This is what your goal of life. Anybody coming with sign and symptom, even in your ER, if somebody come with thrombosis sign and
Yeah, we are
symptom,
giving.
what do you do?
Yeah.
No harm in giving her heparin, right? Give her one heparin
Yeah.
and then do whatever you want to do. At least you have done something good for her. So if they
Will
ask
it be
you
low,
most appropriate
prophylactic or
step,
therapeutic?
therapeutic, my dear, therapeutic dose you have to give because you are suspecting thrombosis, and thrombosis diagnosis sometimes is very complicated. So they tell that by benefit of doubt you should give her. Don't wait
Okay.
for things to worsen.
Yes.
So give her a prophylactic treatment dose and then investigate, and if you feel after that no need, stop it, no problem. But first you should give her. So this is what you want to do. Yes, next question, Dr. Gopa.
A 38-year-old patient is seen at 22 weeks of gestation with acute swelling and pain in her right calf. She was started on therapeutic dose of low molecular weight heparin and has had a Doppler ultrasound scan that is negative for DVT, and she remains symptomatic. So if she's symptomatic but the Doppler ultrasound is negative, so we will repeat it. We will stop the low molecular weight heparin and we will repeat her Doppler ultrasound after 4 days or 7 days. 4 days.
After 3 days and 7 days.
3
to 7
and
days.
7.
So stop treatment is important here because leg ones are not that important. If it is pulmonary, then if you have a suspicion, you will even keep continue treatment. But in leg one, you will stop it and then you will repeat the scan at day 3 and day 7. So day 3 will be correct because day 7 will be late. First you have to do day 3. Ideally it should be
Yeah.
day 3, day 7, but if it is not there, your next step will be day 3. So here
First.
they have taken the word next literally. So only they are telling you about the next step. So next step will be stop treatment and repeat scan in 3 days. Very good. Very rightly you remembered. But if it would have been pulmonary symptom, I would have continued the treatment and repeat the other test like that. Yes. Next question.
Madam, if it is
An
pulmonary,
18
we do edema.
Yes. Pulmonary embolism. What, my dear?
No. If it is a pulmonary symptom, then we will do D-dimer, right?
No, my dear. D-dimer has no role in pregnancy.
No pregnancy.
If it is pulmonary symptom, if you have done CTPA, you can do VQ scan. If you have done VQ scan, you can do CTPA, or you can do the same investigation with a higher person, means who has more experience like that. Either repeat the same
Okay.
investigation or do the alternate investigation, but no role of D-dimer. In pregnancy, still the new talk says that D-dimer is still, it shows that it could be beneficial, but still the clinical application is not there. So in exam, don't choose D-dimer anytime for this thing, VTE.
Okay.
Not yet. Yes. Next question.
An 18-year-old patient is at 35 weeks of gestation, has presented with chest pain and shortness of breath. She has a sinus tachycardia and chest X-ray is normal. Laboratory investigations are normal and she has been started on low molecular weight heparin. So she is with chest pain, 35 weeks, shortness of breath. So we are suspecting pulmonary embolism. We have done chest X-ray. It is normal. So investigations are normal and she is being on low molecular weight heparin. Chest X-ray is normal.
But chest
we are
X-ray,
suspecting
why you're worried about so much chest X-ray? Because anyways, they say that chest X-ray and ECG will be abnormal in 50 to 60% only. So this is not going to be very specific test. You are doing this to rule out other condition rather than diagnosing with a pulmonary embolism. But if she has a duplex ultrasound which shows the DVT,
no.
isn't your
It's
diagnosis
the previous
confirmed?
question. It's the previous question 142.
We're looking at 142, ma'am.
I'm sorry. I
We are
think
doing
I missed it.
142.
Yes. So 35 weeks presented with chest pain. She has sinus tachycardia X-ray normal, lab investigation normal, and she has been started on low molecular weight heparin. Yes. So what next? Whenever chest X-ray is normal, what you do?
Just
We have symptoms like chest pain, shortness of breath, sinus tachycardia. So we would like to
cannot
confirm it with the MRV.
BQ
Oh, my dear.
scan.
See, whenever you are solving an EMQ, you understood now this EMQ from the guideline of VTE diagnosis. So now narrow your vision to VTE guideline. Don't think too much here and there. Now you have only two options. Either chest X-ray will be normal or abnormal.
BQ.
If it is normal, what to do? Abnormal, what to do? So what you will do in normal? In normal, you will do VQ scan, and if abnormal, you will do CTP. This is what the rule, right? Because
Yeah.
if any X-ray is abnormal, further diagnosis will be CT. So abnormal X-ray, CT. Normal X-ray, you want to rule out the ventilation perfusion, which you cannot see in X-ray and CT. So you are doing the VQ
BQ.
scan. So remember it like that. Normal X-ray, VQ, abnormal X-ray, CT. That's it, CTPA. So it will be easier for you to remember. Yes, who wants to read the next two questions?
Shall I read, ma'am?
Yes, go ahead.
A 42-year-old patient is seen at 18 weeks of gestation with chest pain, mild shortness of breath, and a swollen left leg. Baseline investigation include bloods, chest X-ray, and ECG are normal. She has a duplex ultrasound the same day that confirms left-sided femoral Dvt.
Very good.
She
If
is
you
all.
want to,
We should
I
start.
will kill Shilpa. I will kill you today. Don't forget the rule of investigation, please. This is the simplest thing to make right in exam because there will be many unseen thing coming in exam. If you do that wrong, it's okay. But the things you already know, confusing things, you should make your rule and remember it well. Now, here you told that the diagnosis has been DVT by the scan. So, what you will do?
C, CTP.
You don't want to investigate her further, my dear, because she's already diagnosed. Anybody who
So we
has
will treat
DVT
with
in the
the
scan and
therapeutic
chest
dose of
symptom,
Alentic.
it is diagnostic of pulmonary embolism. You don't have to diagnose her further. You only have to treat her. That's it. We will see the
So we
logarithm
should start
after. Don't
with
worry. So you
therapeutic
should
therapy.
start the therapeutic dose. Yes. Very good. Next question, my dear.
A 23-year-old patient is referred by the midwife at 38 weeks of gestation with chest pain and shortness of breath. The symptoms resolve, but the CTPA scan report states no evidence of embolus in segmental or
Sorry. Yes.
slide one.
Yes. You can see
No
now?
evidence of embolus in the yes, ma'am. Yes, ma'am. No evidence of embolus in the segmental or subsegmental pulmonary tree. Unable to exclude smaller peripheral emboli on CTPA. Should we do a MR venography to confirm? Should we do further investigation?
There is no role of MR venography, my dear. You know from where the question is, you know this EMQ is from the guideline. See, that is the benefit of EMQ. You don't have to think too much. You have to narrow yourself to that guideline from which guideline the question has come. That is a good thing actually. 3 questions from the same guideline you get. So don't make your thought wild thinking about everything possible. Only you have 2 investigations, CTP and VQ scan. Now they have given her symptom resolved, but this is a distractor. No evidence in segmental, subsegmental, but cannot rule out. This is the rule of CTPA. There's nothing new in this. So this is a
Okay.
distractor. So just forget about this. Now tell me, symptom resolved, but CTPA scan, you take it CTPA is normal. Symptom resolved, CTPA normal. So what you will do?
We can stop the treatment and
Yes, you can stop the treatment because her symptom resolved. Clinically, she is fine. Your investigation is fine. So that means there was nothing. Right? Clinically, her symptom
Yes, ma'am.
resolved. CTPA is normal because this is a distractor. Any scan
Okay,
has
ma'am.
not 100%, it doesn't diagnose everything, and imaging always has its limitations, right?
Okay,
So
ma'am.
you can refer her back to the midwife-led care is what they are telling. That means she is a low risk, so you can refer her
Low
back.
risk. Okay.
Because you have not started her on
Understood.
treatment. They have not mentioned started on treatment. If they would have mentioned started on heparin, you would have chosen stop. But because they didn't mention started, that's why you have, because she's a low
Stop.
risk, you have
Okay.
referred her back. So this is what your answers
Back
are
to the midwife.
perfectly
Okay.
correct. Now this one. Please, all of you, don't forget this chart, never ever. Always, whenever a women come to you with a sign symptom of pulmonary thing, you are going to do X-ray and ECG, and this is not going to be eliminated. Though the importance of it is less in diagnosing pulmonary embolism, but how do you know that it is pulmonary embolism? It could be MI, it could be any other chest problem, it could be pleural effusion, it could be anything. Until unless you do X-ray and ECG, any heart problem, a patient come to you, what you do? You do ECG, you do chest X-ray, lung and heart. So please don't forget your basic. Any patient coming to you, the diagnosis is not pulmonary embolism. First, you have to rule out other things and make the diagnosis of pulmonary embolism. So chest X-ray ECG you will do, but it is not going to be diagnostic for PE because that is 50 to 60% only. So be clear about that. Then you want to give a low molecular weight heparin, so you will do her blood test for safety because you want to rule out contraindication for low molecular weight heparin. Then you will give them. See here, the first chart, commence low molecular weight heparin unless contraindicated. So ruled out, do chest X-ray, ECG, clinical assessment, rule out contraindication of low molecular weight heparin, and give her LMWH is your first step. Now, after doing this preliminary thing, you came to diagnose DVT because that is not an emergency. First, treating her is an emergency. Then, if she has a sign and symptom of DVT, you follow this. So, no need of X-ray, normal, abnormal, shall I do VQ, CTPA, no need. Whatever the chest X-ray is, it doesn't matter because if she has DVT sign and symptom, an ultrasound confirmed DVT, that is your confirmed diagnosis of pulmonary embolism. No need of doing all this heavy and costly investigation because this is clinically PE and DVT confirmed. So this is PE only. They take it like that. But if it's negative, if you doesn't diagnose anything here, or if there is no sign of DVT, means her leg symptoms are not there, and the scan is negative, in both the scenario, you will depend on chest X-ray finding. If it is normal, you will do VQ scan. If it is abnormal, any abnormal chest X-ray, CT. Remember it like that if you cannot understand things. So even if you remember it like that, it's fine. Any abnormal chest X-ray, do CT. So abnormal, you will do CT. Normal, you will do VQ. If it is confirmed, well and good. If it is not confirmed but you have clinical doubt, either do the alternate investigation or repeat the same test. But continue. Here you are not going to stop. While here, if there is discrepancy, you stop and repeat at day 3, day 7. Here you are not going to stop and you will repeat immediately. Am I clear about this chart? Many times I have taught you all this chart, and again I'm telling you, please don't miss this chart. This is very important for exam, and always question is there from this important chart, and this is the simplest thing to correct in the exam. Clear? Clear, all of you? Okay, good. So now please don't forget this and keep revising it. It's okay. This chart, you know that this chart, VT chart, always there will be exam questions. So always keep it in front of your eyes. Keep revising it till you feel that you are not missing even a single point. So it's okay. Even before exam, if you revise it, it's a good thing because this is always important. Okay, now this one, HIV, everybody's hot favorite. Yes, who wants to read this?
I will read.
Okay, go ahead, Rima.
The women,
Wait. Yes.
the women described below are HIV positive at various stages in pregnancy. For each woman, select from the above option. Above option lists the single most applicable next step in their management. Okay. An HIV positive primigravida presents in labor at 36 weeks plus 6 days. She has been complained on. She has been complaint on combinant ART since 14 weeks of gestation, and her viral load is less than 50 HIV RNA copies at 36 weeks. So she can go for normal delivery.
Very good. So she can go for normal delivery. So what is the rule? If less than 50, she can go for normal. And if it is 50 to 399,
She is for cesarean section.
more than 400 cesarean. Less than 50, normal delivery. What about 50 to 399? Consider CS. Very good, Shilpa. So you will consider. So which is the situation where this 50 to 399 will become recommended CS? Which is the situation where the HIV load of 50 to 399? What?
Rupture of membranes.
Very good, my dear. So if rupture of membrane, this 50 to 399, you will recommend CS. Don't forget, because in exam, they will give you like that. The value is this much rupture membrane, because rupture of membrane in any situation can lead to ascending infection. So then the rule changes. So they might give you an exam different scenario of SROM, and where you will choose recommend CS for 50 to 399 in rupture of membrane. Very good. Next question.
An HIV positive primigravida on CART
It's
since
okay.
CART since 18 weeks of gestation comes to the hospital for her routine antenatal visit at 36 weeks. There are no complications with the pregnancy, and an ultrasound scan confirms the baby is in cephalic presentation with normal growth. She has a viral load quantification which is reported to be what is this 500 copies. So she is for cesarean section.
Yes. So what time you will do the cesarean section for her?
For her cesarean section 38 to 39 weeks.
Very good. So 38 to 39 weeks you will do the cesarean section. So this is what I have already discussed. VBAC, you can do the VBAC if it is less than 50, the same as vaginal delivery, and CS will be done between 38 and 39 weeks. That's why you do the viral load at 36 weeks so that you can plan the delivery. In SROM, as I told you, the rule changes. The other thing, important thing, they ask you about the baby, how you will give the baby prophylaxis. Before going on that, I want to ask you a few more questions. When you will start ART for her and when you will stop? Will you start ART for all pregnant women?
No, we will start and for all, including elite controllers, and we will never start in postpartum.
You will never stop in postpartum, right?
Yes, we will
This is
continue
what
lifelong.
Yes, this is what the recent recall, you will not stop it because the rule has changed now. You will continue it postpartum, never stop. And earlier, elite controller, no need of giving. Now the rule has changed that you have to give even for elite controller, means very good control also you are going to give. So everybody should receive ART, everybody should continue it postpartum. Now, what time you should start then? What time you will start, it will depend upon the viral load sometime, but at least, very good, my dear
At
Srivastava,
least by
at least
24
by
weeks, all
24
should
weeks,
start.
everybody should start. So this is important. By 24 weeks, everybody should start. But if the viral load is more than 100,000, even in first trimester, you can start. So you can start even in second trimester, early second trimester, even in first trimester, very high load. But all should start by 24 weeks is your goal. Now, then you will check her levels at 2 to 4 weeks after starting, and then every month you will check, and then 36 weeks level you will check, and accordingly you will deliver her according to the level. So this is important. Now, I want to ask you about the recent recall, which this anti-HIV drug leads to neural tube defect.
Is it dolutegravir?
Very good. Dolutegravir, if you give less, they say that dolutegravir you should give more than 6 weeks. If you give less than 6 weeks, there is chance of neural tube defect, and this is a recent recall question, so don't forget this. Dolutegravir is a integrase inhibitor, and they say that if the load is too much or somebody come in labor and all, you have to give integrase inhibitor. So dolutegravir is quite famous nowadays, so don't forget about it. Neural tube defect can happen with dolutegravir. What else? You have started, you have not stopped, and you have monitored, you have delivered. So then comes the baby. What you will do for the baby? Baby could be very low risk, or high risk according to the criteria. If they will give you an exam, only one viral load less than 50 at 36 weeks, that doesn't fill the criteria of very low. Because for very low, you have to have two values less than 50. All three criteria should fit. Longer than 10 weeks, two values, and less than 50. If only one thing is fulfilling, then it is low risk. So very low risk is a new category introduced where all the three rules are fulfilled. If one rule only fulfilled of less than 50, it comes in low risk. So please don't confuse it, because in exam, they can give you in EMQ form, in any form, these three categories. And if it is high risk, where the viral load is more than 50, you will give combination post-exposure prophylaxis for 4 weeks. So 4 weeks zidovudine monotherapy and 4 weeks combination PEP is what you are going to give. So these are all important HIV questions you should remember. Yes, who wants to read this now? Yes, anyone can read.
I will read.
Anybody who has not read yet want to read? Let them take a chance. Don't be afraid. You can make it wrong. You can do whatever. Make it wrong here rather than in exam. So let us discuss. If anybody else want to read, go ahead. Dr. Shazi, unfortunately, your signal is really weak, my dear. I cannot hear you.
I will read first question.
Okay,
I
go
will
ahead.
read.
Two
Yeah,
for
30.
Dr. Gopa and two for Dr. Reema. Yes, Dr. Gopa, you can read the first, second, and Dr. Reema third and fourth. Yes, go ahead.
For each of the questions, choose the single most appropriate management option from the list. A 38-year-old woman presents to the A&E with generalized tonic-clonic convulsions and becomes unconscious. An ultrasound report is found in her medical record which shows a live 10-week intrauterine pregnancy. So, management. So, unconscious means we have to do that ABC, airway,
Yes, very good.
phase,
Yes, you have to
oxygen.
first do the resuscitation program for her because she is having convulsions. So that is your first step. And that is the most appropriate step. Otherwise, she might die even for tongue fall or something else. So better to do that. Next.
A 23-year-old primie is noted to have a BP of 150/90 at a routine antenatal visit. She recollects mild intermittent headache but is otherwise asymptomatic. She is now 18 weeks pregnant and has no proteinuria. So she is 18 weeks with no proteinuria. So gestational hypertension.
Yes. So
So
what you will do?
we'll start antihypertensive of 150/90. We'll do
Very
those
good.
blood investigations, but we'll start her on treatment, no,
Yes, you will do, but
150/90.
because they asked single most appropriate management, so you will do the investigation, yes, but your most appropriate management is to start her antihypertensive, right?
Hmm.
If they will ask me next step, you will do the blood investigation, but still the next step also will be giving her antihypertensive. You are not going to delay her antihypertensive till you get a blood investigation. You will do that simultaneously. That is a different story. But here it is not like you want to rule out some contraindication or something. Anybody with high BP come, your first job is to give them antihypertensive. And this is what you do in your clinical practice, right? So you will start her because it is more than 140/90. Yes, Dr. Reema, you can read the next two.
A 30-year-old second gravida records a BP of 160/100 when she attends the day assessment unit for her fetal monitoring. She is now 30 weeks into her pregnancy. Urine shows 4+ proteinuria. Further analysis shows serum uric acid 6.8 and normal CBC with mildly elevated liver enzymes. IV access is obtained immediately. Blood investigations are sent. The bladder is catheterized and she is shifted to the high dependency unit. So we need to start her on antihypertensive and magnesium sulfate.
Very good. So what you will choose, antihypertensive or magnesium?
Antihypertensive first, IV labetalol.
Very good. So answer should be IV labetalol, but here the mistake in question formation, they have no answer of IV labetalol because your first job is to give her antihypertensive because she's severe hypertension. Yes, in severe hypertension for prophylaxis, you have to give her magnesium. That's a different story. But first is to give her antihypertensive altogether. You should get an option of antihypertensive first. If they would have given that antihypertensive has been started, then you will choose magnesium sulfate. So in exam, the questions are clear, don't worry. And here they have only comments oral, though you can start oral also for severe hypertension. So here you will choose oral labetalol because that is your first job. Give her antihypertensive is your first job, and then your next job is to give her magnesium. So be clear about that. Next.
Dr. Shweta, we cannot start hydrolysine as the
Hydralazine is not your
antihypertensive.
first choice. Hydralazine is not your first choice, and it will always be with IV fluid. So first you have to give her 500 loading and then hydralazine. First choice is lobetalol, so you will choose lobetalol first. If not controlled with that, you can choose hydralazine. As lobetalol is always our first drug of choice, right, in pregnancy with hypertension. So first you should choose lobetalol, then ifidipine, then hydralazine. Yes, next question, Dr. Reema.
A 30-year-old, a 30-year-old primary gravida is admitted in spontaneous labor at 37 weeks of gestation. Her antenatal period was uneventful. Her blood recording is 140/90 BP and proteinuria 1+. It is, I can't read it is not clear. The rest of the
She's
I
now
can't see.
having regular, I will read it for you. She's now having regular uterine contraction and vaginal examination shows 3 centimeter dilatation of cervix.
Okay, she's now 140/90. This is a mild preeclampsia. We need to monitor, and at this point, she doesn't need any treatment. 140/90. Augmentation of the labor.
Why augmentation? She's getting regular contractions, so no need of augmentation. But anyways, I don't know what is the answer. What other things they have given? Nothing else fit, then you can choose that also. Admission, airway, betamethasone, continuous fetal monitoring. There is continuous fetal monitoring.
Maybe the investigations we need to do, but
yes, that is a good choice. Do an investigation because this is a preliminary. First time you have diagnosed her as proteinuria and all that preeclampsia. So first you have to see this. This is a safety point because maybe her coagulation is deranged, maybe something is LFT is high, maybe uric acid is very high. You don't know. Proteinuria is not a criteria to judge the severity of hypertension. So you should do the blood investigation. This is what you do, right? In your practice, whenever you get a high blood pressure patient, you do the protein, you do the blood investigation. So that should be a good option, blood investigations. Okay, so here this is, I think it is wrong key. So if you see in the medical management for anticonvulsant, they say one or more of the following: ongoing recurring severe headache, visual problem, nausea, vomiting, epigastric pain, oliguria and severe hypertension, progressive deterioration in the blood test. So please be careful, progressive deterioration of the blood test. Not only one abnormal, progressive deterioration. So these are important, oliguria important, They have here not mentioned the protein. Earlier there was protein, but now in new guideline they have removed the protein. So be careful about that. In antihypertensive, you can give labetalol oral or IV, oral nifedipine, IV hydralazine. Nifedipine never sublingual. Please be careful because if you give sublingual, sudden drop in BP dangerous for baby. So be careful. Whenever you give IV hydralazine, you have to give 500 ml crystalloid. And for maintenance fluid in severe, you will give only 80 ml. So these all are important things about antihypertensive and anticonvulsant in severe preeclampsia. Yes, next question. Who wants to read this?
Shweta, I'll read.
Yeah, go ahead, my dear.
Okay, the woman described below developed chickenpox either in pregnancy, labor, or postpartum. Choose the most appropriate management from the above list. 37-year-old primary Gavita seen by her GP with chickenpox. She developed the rash 18 hours ago. Okay, she's 37 years. Okay. Of note is, in fact, that she smokes 20 to 30 cigarettes per day and has been coughing throughout the pregnancy. She is currently 22 weeks of gestation. When examined, there are no signs of chest infection or neither systemic symptoms. So we said she's 37 years old, primary gravida, and she smokes 20 to 30 cigarettes per day. Isn't it going with the IUGR protocol?
Now
No,
here,
sorry. This here chicken. Okay.
here you have to talk about chickenpox because they already told you chickenpox. So narrow your brain to chickenpox guideline and think about it. What all positive thing they are giving you?
Yes.
They gave
Yeah,
you
rash
rash 18 hours ago.
Yeah. So we can start this one. We can start the treatment because within 24 hours.
Yes, very good. So what you will start?
Acyclovir.
Yes, you will start acyclovir. What is the dose?
800 TDS for 7 days.
Very good. Now, why they have given you all this extra information of smoker and 22 weeks? Why they have given you this? Does something click in your mind by seeing this thing, something written like this in the guideline?
For me, I was suspecting this one, the IUGR for SGA protocol in high risk. She's high risk lady.
Varicella pneumonia?
No, but what in
Refer to
chickenpox
hospital for
guideline, what they have
assessment.
mentioned?
Referral to hospital.
This one, hydroxyphilus.
It is an indication for a
No,
referral for
whenever,
hospital assessment.
yes, it is an indication for referral for hospital assessment. I will tell you, wait,
Okay.
show you this. Hospital assessment you have to do if she smokes cigarette, if she's chronic lung disease, if she's immunosuppressed or second half of pregnancy. So they gave you 22 weeks. They gave you smoker. So her lung is compromised. Basically, what is the reason in chickenpox? There is pneumonia and the death, up till 14% death. So you want to, this patient, you want to be more careful because their chance of getting deteriorated with pneumonia and death is more because their lung is affected. In second half of pregnancy, already everything is compromised. So second half of pregnancy, smoker, chronic lung disease, and immunosuppressed who has received steroid within 3 months, you are going to do the hospital assessment. That's why they have given you all this. And you will refer to hospital if she has respiratory problem, neurological problem, hemorrhagic rash, or dense rash. So these are indication for referral. These are for hospital assessment. That's why that particular line they have given you in the question. So that, as I told you, narrow your vision first and then focus on the guideline. Automatically, it will click in your mind what you read in the guideline. Yes. Next question.
Okay, 25-year-old primary Gavita who suffers from gestational diabetes has been booked for induction of labor at 39 weeks of gestation. Her diabetes is well controlled along with diet, and she's seen by the midwife today at 38 plus 5 weeks of gestation with a rash, which developed 48 hours ago. That is typical of chickenpox. She was seen by her GP and referred to the hospital for review. Okay. So now she developed the rash within 48 hours and we will delay her delivery by 5 days. So 7 days will delay the delivery.
Very good, my dear. So you want to delay her delivery by 5 days. So defer her delivery by 5 days, not 7 days, because already 48 hours is over. Very good. And here you will refer to hospital for assessment and acyclovir will be your answer. Very good. So this is how you should be thorough in your reading to understand all the small tits and bits and you can answer. The rule with chickenpox is in UK, they are 90% seropositive. That's why they always tell you that check the blood, check the blood. If she's positive, no risk. How long the rash is infectious? 2 days prior to 5 days after the rash. Why it is important? If they will give you more than 5 days, then it is non-infectious. So you shouldn't be worried. So this duration is important. Then how much is the chance of the baby to grabbing it? How much is the chance of fetal varicella syndrome? What you will do? What you will do when she comes to you with exposure and no rash? The rule number one with exposure, no rash means immunoglobulin. If the rash come, you have to look for in the question, is it less than 24 hours, more than 24 hours? If less than 24 hours, give her acyclovir. If more than 24 hours, you cannot give her acyclovir, just symptomatic management. So this is important. When you give her immunoglobulin, her infectivity will increase. Usually it is 21 days. By giving immunoglobulin, you are making it to 28 days. And sometimes you can repeat the immunoglobulin after 3 weeks. So these are all important points you should remember and it should be crystal clear in your mind that stepwise how you are going to take the management of chickenpox in pregnancy. Then acyclovir is always their favorite drug. So know everything about acyclovir. 800 milligram 5 times a day for 7 days. While in herpes, it is 400 milligram 3 times a day for 5 days. So all less. Acyclovir within 24 hours and if 20 weeks or beyond. So if they give you 20 weeks in the question, they want to talk about acyclovir. Always they talk like if they want to talk about aspirin, they will give you 12 weeks in question. If they want to talk about that particular thing, they will talk about that particular thing in that particular gestation. So EMQ like this, you have to smell what they are trying to tell you, where they are dragging you, what they want to ask you. Then you will be able to make the answer correct. But it is not mandatory that she has to be 20 weeks. If she's severe chickenpox, even you can give her acyclovir before 20 weeks. So this is important. Not licensed for use in pregnancy, but you can use the same way like you use artesunate, artemisinin and all that. Many things are not licensed in pregnancy, but you can use after informing the women. IV you can give in severe chickenpox, so be careful. Whenever they give you severe scenario, you can choose IV. No increased risk of malformation with acyclovir, so this drug is perfectly safe for pregnancy. This we already discussed, referral and assessment, and this is really important to remember. Neonatal risk. The other important thing they ask you about neonate, how much is the risk, what you will do. Now, if she has come to you after 24 hours, now you don't have to do anything for the mother, for her relief or whatsoever, symptomatic relief only, no acyclovir. So then you have to recheck for the baby, right? So for checking for the baby, it will be in after 5 weeks of the infection or around 16 to 20 weeks. You will do the scan to look for if baby has any varicella syndrome, or you will do amniocentesis to check for if there is any infection in the amniotic fluid. If amniotic fluid show negative, you are happy. It's sure. But if it is positive, not necessarily it is 100%, because if you see the transmission rate and fetal affection rate, fetal varicella syndrome is 0.5% only in first trimester and 0.9% only with less than 20 weeks. So it's not 100%, it's only less than 1%. So getting it positive doesn't make sense, but getting it negative makes sense. So that's why you have to do amniocentesis. That's why you have to do the scan so that you can counsel the mother what to do, when to do, how to do, right? And then around delivery, what is the risk? If the maternal infection is in the last 4 weeks is a dangerous time. So there will be chances of 50 up to 50% infected and 23% the baby can develop clinical varicella. So in last 4 weeks, you are more worried. You will allow the planned delivery at least 7 days after onset of rash to allow the passive transfer of antibody. This is very important. And if mother had pox 7 days before or 7 days after delivery and she delivered, she's in labor, you cannot stop it. Planned delivery you can avoid. But unplanned delivery, what you will do? If she deliver within 7 days, then you will give the baby IV immunoglobulin with or without acyclovir. So these are the rules you have to remember for chickenpox. Clear, all of you? Before we go to diabetes. So we revised hypertension, we revised HIV. What else we revised? Varicella we revised. We will be revising diabetes already half we have revised. So all the important headache we revised. So many things we have revised. Good. VTE we revised fully, both the guideline. Good. Yes. So let's go to the next question. Who wants to read this? This is the last question for the day.
I will read, ma'am.
Yes, go ahead, my dear.
For each of the following questions, choose the single most appropriate option from the list A to N. Each option may be chosen once, more than once, or not at all. A 28-year-old primary gravida attends the combined diabetes antenatal clinic for consultant-led care at 8 weeks gestation. She has type 1 diabetes and is on insulin. Her BMI is 28. Her most recent blood profile is as follows: fasting blood plasma blood glucose level of 6 millimole per liter and HbA1c of 6. She monitors her glucose and undergoes annual retinal screening.
What do you think?
Her fasting is slightly elevated and HbA1c is also mildly elevated. She is already on insulin.
HbA1c less than 6.5, you're happy, right? She's type 1 diabetes already.
Yeah.
So HbA1c is 6, so acceptable. Fasting 6 is acceptable. She monitors and did regular screening. So she is a good lady. She has done a good job. Her BMI 28. So for me, it is looking like all good with her. So what do you want to do with
Go
her?
with option D, folic acid, diet and exercise along with monitoring.
Yes, very good, my dear. My dear Revti, you will not think about aspirin at 8 weeks. As I told you, at 12 weeks. So EMQ, always you have to go step by step. That is how you will be able to choose the right answer, because there are 20 options. If you don't narrow yourself, it's difficult. So here she's looking all good. She's 8 weeks pregnant. You don't have to do anything. Only give her advice that you have to take folic acid 5 milligram, because in diabetes you have to take high dose of folic acid. So folic acid, diet, exercise is what you will advise her. But if they give you 12 weeks here, my ear will be alarm for aspirin. So think like that. Try to think like that in EMQ especially, because otherwise it's very vast thing, never ending thing. Yes. Next question, my dear.
A 34-year-old primary gravida is seen in the antenatal clinic at 32 weeks gestation. Her BMI is 28. Her growth scan showed polyhydramnios. Her 20-week anomaly scan was normal. Her oral GDTT was 70 with 75 gram glucose is 7.8 millimoles. HbA1c is 8. Her renal parameters are normal. So she is 34 at 32 weeks gestation with an increased BMI and polyhydramnios. So her fasting is elevated. Her HbA1c is also raised. So in this case, I think I would start her on insulin because she already has one complication of diabetes of GDM, which is polyhydramnios. So the answer would be insulin treatment.
Are you starting insulin for polyhydramnios, or you are starting insulin for something else? We should know our rules. For EMQ, you should remember, okay, in this question, you're right. You chose insulin, the answer is right. But your concept should be right, right? You should remember the rule, because next time I will not give you polyhydramnios. Then what you will choose?
Ma'am, her fasting is also elevated. It is more than 7.8. So
what is the rule? That is what I'm asking. Trying to sit you.
6 to
Very good,
6.9
my dear.
with additional findings, we add insulin, no, ma'am. If we have
Yes, that
polyhydramnios.
is also correct. If 6 to 6.9 with poly, you are going to add. If more than 7, you are going to add. Both ways it is correct. I'm trying to revise the rules. I'm not telling your answer is wrong. I'm telling your answer is right. But try to revise the rule and be specific why you're doing it. So what is the rule? If 6 to 6.9 with abnormality like polyhydramnios, big baby, you're going to start. Or if fasting is more than 7, you're going to start. So here anyways, the fasting is more than 7.
Okay.
So it's not applying 6 to 6.9 with poly. It's applying more than 7. Here, the rule is. Which rule
Yes,
is
ma'am.
applying? More than 7 is applying. You
More
get
than
my
7.
point? Because
Yes.
tomorrow in exam, when you get the question, there might be no poly. So you should be clear about your rules. so that whatever twist and turn they will give you in exam, you will be able to handle it well. Yes, next question, my dear.
A 39-year-old second gravida is being reviewed after her third trimester growth scan at 37 weeks, completed weeks. During her first pregnancy, she had fetal demise at 29 weeks gestation and labor was induced. She has type 2 diabetes and is on insulin, metformin, 750 mg twice daily. Her BMI is 30. Her most recent blood profile is as follows. Fasting is 6.2, HbA1c 6.5. The ultrasound is with the normal limits and the AC remains above the 97th percentile. So in this case, she's a 37-week multigravida with previous fetal demise with controlled sugars with a high BMI. In this case, the option would be.
So what is abnormal in this question? Do you find anything abnormal or you feel everything is perfect?
The AC measures above 97th percentile. That's
very. So that is the only thing we see which we don't like. And she's 37 weeks. So what do you think? So they are giving you 37 weeks. So what they're trying to ask you?
Madam, she's already on insulin. So usually we'll induce them at 38 weeks.
30, it's not 38 actually. You will induce, you want to deliver her between 37 to 88 plus 6.
38, 37
Any
plus 6.
abnormality, you are justified to deliver her after 37 weeks, right?
Okay. So induction of labor.
You want to, no, not, I'm not telling you will induce her. I'm telling you, remember the rules. Rule is you have to deliver her between 37 to 38 plus 6 weeks between this time period. So either you can induce her now or even at 38 weeks. So 37 to 38 weeks you will induce her so that she will deliver before 38 plus 6, which is what your goal is. Anything, anytime, if it is uncontrolled, you can induce her from 37 weeks. So what should be the answer according to you?
Induction of labor at 37 completed weeks.
Yes, that's a good answer because you have to induce her because this is abnormal, 97th percentile, and you are justified. Your rules say that you can induce after 37. She should deliver between 37 to 38 plus 6. So you can do that.
Ma'am, the two options are there. F is induction of labor at 37 completed weeks and K is offer induction of labor. Here the question says 37 completed weeks already. So what do we pick in that case? How do we decide?
I think more specific you should pick because 37 fall in your rule. So you should pick induction of labor now. Induction of labor when? Offer induction of labor means the same thing. You are offering her induction of labor now.
So we pick offer
actually this is synonym. Both the things are synonym. Offer IOL means offer her IOL now. IOL at 37 is basically, as I tell you, it is not the fault of question makers. Even when I make the question sometimes, by the time I make the question, by the time I make the option, sometimes there will be duplication, sometimes there will be similar words. It can happen. So both are similar things. Both are correct. But it is the formation mistake of the author. But don't worry, in exam you will not find things like this. So you can offer her induction now itself. Yes, so these both are synonym according to me. So it doesn't matter whatever you choose here. But in exam, you should understand that you can induce her at 37.
Okay, ma'am. Thank you.
Okay, dear. Yes. Next question, the last one.
A 30-year-old second gravida woman attends the antenatal clinic with a NT report at 13 weeks of gestation. She developed gestational diabetes in a previous pregnancy and was on metformin. She had an emergency cesarean section at 39 weeks for failed. I'm not able to read the last line. It is not visible.
Okay, no problem, my dear. I think because of the line. So she has an emergency cesarean section at 39 weeks for failed induction. Her sugar levels were completely normal 6 weeks post-delivery. So they are telling that she has previous gestational diabetes. She had cesarean section. 6 weeks post-delivery, her sugar was normal. So that means she was GDM only. After that, it didn't continue. Now she came to you at 13 weeks with NT scan. For NT scan at 13 weeks, what you will do?
I would do an OGTT.
Very good. Very good. You want to do OGTT because she has previous history of gestational diabetes. You want to do one now, and then you want to do repeat at 24 to 28 weeks. This is what, if they will give me this option, that OGTT now, and if normal, repeat at 24 to 28, that will be more justifiable. So please be careful about close options. But first you have to narrow down your options by looking the weeks of gestation, where they are directing you, what they are trying to tell. And then here, here I want to choose IOL. So I will see all the option of IOL, IOL at 37, IOL at 40 for IOL. So I will read that one only. I will not read all others because I'm looking for an option of IOL. Here, because I'm looking for OGTT, I will directly look for OGTT. And then what all options close to OGTT, 1, 2, 3 option, I will differentiate from them. What is your doubt, my dear Shilpa? I couldn't read the earlier message because I was talking. Yes, tell me. 13 weeks. Yes, anytime you can do OGTT, my dear. That is what they told. Either booking. Booking means 10 weeks even. So even at 10 weeks, 11 weeks, 12 weeks, first encounter, remember it like that. As I told you, 12 weeks, they are taking you towards aspirin. If she's 13 weeks, she has been already started on aspirin. You get my point? You will assume that the work has already been done of 12 weeks. Because in EMQ, always you have to assume some things. Everything will not be in the question. So because she's 13 weeks means 12 weeks is over now. So you cannot choose this. Clear? If they'll give me 10 weeks also, I will choose OGTT. If they'll give me 12 weeks, I will choose aspirin. Clear to all of you how they make the EMQ and how they want you to approach towards it? Until as you understand all this rule of how to solve the EMQ, believe me, it's very difficult to make a right choice. Okay, so this is how you all went it and did it well. So really, you all came to the answer correctly. Which one to repeat, my dear? Can you identify yourself, my dear? Can you tell me your name? AD, very nice short form of your name. Anusha, hi Anusha, how are you, my dear? Nothing, I was talking about the diabetes that if she has previous history of diabetes, you have to do 2 times OGTT, one at the first encounter and one, if that is negative, repeat at 24 to 28 weeks. And in EMQ, always be careful about the weeks of gestation, what step they are talking about, so that you can choose the right answer. Okay, so pre-pregnancy planning, very important. You have to give her high dose folic acid. You have to tell her to optimize her BMI, diet, ketone meter, glucose meter, everything. Which is your aim of HbA1c? This is also SBA question in exam 48. If it is above 86, you will terminate the pregnancy, because if she become pregnant, anomalous baby. Type 1 diabetes, your goal is this. This is also recall question 5 to 7 or before meal 4 to 7, and monthly measurement of HbA1c. So these are all your pre-pregnancy planning for diabetic women. Then they tell you what is your goal during treatment. So fasting 5.3, 1 hour post meal 7.8, and 2 hours 6.4. So everything is a question in exam. Treatment of GDM we already discussed. If it is less than 7, first you will give a trial of diet, exercise. After 2 weeks, metformin. If not, control insulin. This is your series. If it is more than equal to, please be careful, more than equal to 7. This is less. More than equal to 7, immediate insulin offer, and along with diet and exercise. If it is 6 to 6.9 and complications like macrosomia or polyhydramnios, consider insulin. So this is what you have to be careful with the wordplay in the exam. Intrapartum care, they ask you how you'll monitor the sugar, how frequently you will monitor, when you will deliver her, everything. So you will deliver type 1, type 2. This is also recall question 37 and 38 plus 6. If gestational, no later than 40 plus 6. That means you will induce her by 40 plus 2, 40 plus 3, so that she will deliver before that. She'll deliver before 40 plus 6. Because after induction, it may take 1 or 2 days. So you have to give that much leverage. So anybody 40 plus, you are going to induce in gestational. Anybody 37 plus, you can induce in type 1 or type 2, or you can do CS between this range. So be careful about this. VBAC you can do if you want, the same way as we did in HIV, as we did with herpes or whatsoever. Monitor every hour and your goal is 4 to 7. Don't forget this. This is also recall question. Between 4 to 7, it should be maintained. And if it doesn't maintain, you have to give her insulin dextrose drip. So please be careful about that. Then they ask you about postnatal monitoring. Then they ask you about baby. They ask you that you should start breastfeeding within 30 minutes, give her every 2-hourly feed. If any time capillary blood glucose is less than 2, evaluate and give her dextrose, the baby. So these all things they ask you. Then they ask you postnatal monitoring, what you will do. 6 to 13 week only fasting. After 13 weeks, either fasting or HbA1c, but never ever choose OGTT in postnatal. Please be careful. Fasting till 13 weeks, after 13, either fasting or HbA1c, and later on annual HbA1c is what you are going to offer her. And if HbA1c is more than 6.5 or fasting is more than 7, it indicates likely diabetes. So this is what they always ask you in exam.